So it's a great honour to be talking to you all today about TSC and the skin. So conflict, I haven't got any relevant conflicts to declare, but I do have a disclaimer, and that's that I'm only a dermatologist. So although I have an interest in TSC and other genetic skin diseases, the skin is really where my expertise lies. So if you ask me questions about other things, I may or may not be able to answer you. So a lot of my work, as I've said, is with genetic skin diseases, and that includes TSC. And this is where I do my clinical work is St Thomas's. We look across the Houses of Parliament and probably get a rather nicer view looking at them than they do looking across at us. We're in the old part of the hospital for our clinical work, seeing people, children and adults with genetic skin diseases in our rare diseases centre. And there are a variety of different rare genetic conditions that we see there, including TSC. And this is the waiting room of our lovely rare diseases centre that opened in 2017. The rooms are lovely, the lighting's great, there's a little garden out the back where people can hang around. And really the whole idea about the waiting area, as you can see here, is that it's very conducive to meeting and mingling of people that are waiting to be seen in their clinics. We know it can be very isolating if you have a rare disease, particularly a rare skin disease. You might feel like you never meet anybody else with the same condition. But with this waiting room and the table that people can sit around and natter at, the idea really was very much to bring people together and to try and do away with that sense of isolation, having a rare condition, that you're not alone and you will meet other people with the same kinds of problems when you come to our clinics there. So we're very lucky to have this super duper space to work in. So I know a lot of you on this call are going to be total experts in TSC because you live with it yourself or your loved ones are affected by TSC, but just a little overview slide and then we'll move into the skin. So we know that it's not uncommon. It's a rare disease, but it does affect 1 in 6 to 10,000 live births. So as the sort of rare diseases go, it's one of the more common ones. So it affects a lot of people in the UK. And we know it's a condition where you get overgrowth of different tissues to give you benign tumours or benign swellings. So that can affect lots of different areas. It might be the brain or the eyes, systems like the heart, the lung, the liver, the kidneys, and the skin. We know that epilepsy is a very frequent problem and a very important clinical problem, and that sometimes cognitive and behavioural issues are really at the forefront for people who are affected with TSC. And there can be an increased risk of malignancy. And those of you who've got the condition will know that monitoring and follow-up are vitally important. But over 90% of people have skin affected as part of their TSC. We know there are 2 different genes that can be affected, TSC1 and 2, and that it's a dominant condition. So by saying that, it's something that comes down through the generations. So somebody affected with TSC has a 50% chance of passing it on to any of their children. However, in around 80% of people with TSC, it arises as a new spelling mistake. So there's no one else in the family, no parent affected with it, but it's just a new thing that's happened. And that happens not uncommonly in genetic disorders. Everything has to start somewhere. So why is the skin important in TSC? Well, there's a number of different reasons. First of all, as I've just said, skin problems are extremely common. Almost everybody with TSC will have at least one feature of the disease affecting the skin. And importantly for doctors working in that area, it may be the initial thing that makes somebody be concerned that TSC might be a possibility. It's there as an initial presenting feature. And for that reason, it can be very helpful to pick up on those signs in the skin to help you make a clinical diagnosis. Now, apart from those reasons, I think it's really important because we know that skin diseases of whatever cause can have a really significant psychological impact. Living with a visible difference is very difficult. And I think if you have a condition that may have so many different facets, like TSC does, you may have epilepsy, you may have other sort of systems involved. Very often talking to people with TSC, it's actually the skin problems and that visible difference that has one of the major impacts for them, because it's how you present yourself and what people see when they meet you for the first time. And so that's why it's really important, if someone is affected psychologically by the impact their TSC is having on their skin and their appearance, that's given emphasis, and that you do what you can to try and make things as good as they can be for that individual living with the condition. Some of you will be familiar with these diagnostic criteria. When we learn as doctors and healthcare workers about TSC, we see tables of criteria. So this is how you can diagnose somebody clinically as having TSC. Obviously, we've got the genetic test to back it up. But these are the ones if you were just thinking about the clinical diagnosis. And to make a definite diagnosis of TSC, you need 2 from the major group, or 1 from the major and 2 from the minor group, or a possible diagnosis that you might then want to follow up with genetic testing based on 1 major feature and at least 2 minor features. Now, why I've put these here is if we look at the ones that involve the skin, you can see these are very important. So they're an important fundamental part of our diagnostic criteria for TSC. So what are those changes? And I'll go through some examples to show you of all of these. So the facial angiofibromas, these occur in about 3/4 of people, and they can be a real major problem because they're on the face and they can be red and they can be very noticeable. So a major issue for a lot of people with TSC. Shagreen patches in at least half people will develop. These are usually on the lower back, so they're not somewhere as obvious, but can cause a certain degree of psychological concern as well. Hypomelanotic macules, these used to be called ash leaf patches. The term hypomelanotic macule tends to be better because they're not always ash leaf shape. And these occur in almost everybody, 90% of people. The fibrous cephalic plaques, or the forehead plaques, in around 1/4 of patients. Confetti pigmentation is something I'll show you in a moment, but it comes on sort of over time with little itty-bitty kind of reduced areas of pigmentation. Ungual fibromas, these can be a very annoying and difficult problem because they can affect the fingernails and toenails and interfere with function quite a lot, as well as altering the appearance of the hands and the feet. And then gingival fibromas, these are little fibrous lumps that you find around the gums and in other places in the mouth. You might think that's a bit weird for a dermatologist to be talking about, but as dermatologists, we don't just stop at the lips. We include the oral examination as part of the skin. So that's why it falls in our domain. Now, not all skin changes are there at all times during life. So some things come on early, and we'd expect to see them sort of in the early days or months or years of life, and other things come on more gradually. And that may be significant if you're relying on those diagnostic criteria and for things to be there to fulfill a clinical diagnosis. So the hypomelanotic macules, you can see, really present in the first few months of life. They're usually there at birth or very shortly afterwards. They tend to be much more noticeable in darker skin types than if you've got very pale skin, but really they're sort of there at birth or shortly after and persist thereafter. The facial angiofibromas tend to come on in the first decade of life, so they increase up to their maximum and then remain fairly stable, although if they're present in an individual, they might get more prominent and more lumpy or bumpy over time. The Shagreen patches similarly aren't usually so noticeable at birth, but will tend to increase in frequency through childhood. And the periungual fibromas, not there in the first few years, but increase in incidence as you go through the first couple of decades of life. So some examples of these things. So these are facial angiofibromas. So if you look at the top left-hand side, you can see there's some little flesh-coloured bumps. They're quite subtle there. But what happens is they can become much more red and much more bumpy over time. The site is very typical, so they tend to be on the medial, the inside part of the cheeks and over the nose. And they're called angiofibromas. Angio relates to little blood vessels that are present in those bumps, and the fibroma just means it's a little fibrous bump, so angiofibromas. And these are Shagreen patches. So shagreen these are named after a type of leather that you typically get from sharks or dogfish, which is a very textured kind of leather. And that's sort of represented really in the kind of textural change that you get in these patches. They can be reasonably flat, just sort of soft little raised texture to them, or they can be a bit lumpier, as you can see on the right. And typically these occur on the lower back. So if you sort of suspect as a dermatologist that someone might have TSC, this is a site that you would go and look for shagreen patches. And here we've got some hypomelanotic macules. So for a diagnosis of TSC, you need at least 3 of these, and each needs to be at least 0.5 centimetre in size. It's not uncommon for children or young people to have 1 or 2 of these. But really in TSC, you would expect to see at least 3 of them. An isolated one on its own doesn't really signify anything, but these are very, very common. Most people with TSC will have these. And then the fibrous cephalic plaque. So fibrous just means it's quite thickened tissue. Cephalic means it's on the head, and plaque is just that it's quite a large raised area. And you can see on the top left-hand side in this chap with darker skin, they're often a bit darker in darker skin types. And in paler skin types, they tend to be more reddy brown or flesh coloured, and they can occur within the scalp and become quite lumpy. And that can be a real nuisance and a problem. If you imagine cutting your hair or combing your hair, they can become a bit caught. And certainly because they're on the face, they can be a sort of cosmetic concern affecting someone's appearance. And then we've got some ungual fibromas. So these are slightly more common on the toenails than they are on the fingernails. And as we discussed before, they tend to come on and become more prominent over time. So they might just be little fleshy bobbles like you can see on the big toenail at the bottom left, or they can become more pointed with little fibrous areas towards the tips, and they're really annoying because they can catch on things, particularly on the fingernails, or the toe ones can catch on your socks and become very uncomfortable. And they can also create grooves and problems in the underlying nail. So very often people would prefer to have these removed, which can be done surgically. It's not a big deal to do that, and that can certainly improve the appearance and also reduce the inconvenience of having these. This is the confetti pigmentation. You can see these little white areas of skin with no textural change. And then gingival fibromas, you can see where the arrow's pointing to the gum, this little fibrous bump there. And then down at the bottom left-hand side, you can see there's one on the inside of the lip as well. So these are other signs of TSC. So how would we manage the skin? Well, I think first of all, a full skin examination when someone first presents so that you can document what's there. Does this help us with our diagnostic criteria? And then ideally to see people once a year or sooner if there are any concerns at all about the skin. For those hypomelanotic macules, it's really important to use sunscreen. And the reason is those areas of skin can't tan, so they can't protect themselves from UV rays. So they're very prone to getting sunburnt. So it's really important to use a high factor sunscreen. And when you look at a sunscreen bottle, you'll see 2 things. One will be a number, so SPF 30, say, or 50. And that number relates to the protection it gives you against the UVB rays in sunlight. And UVB rays tend to be the ones that can cause sunburn. So that's very important to avoid burning. But also when you look at your tube of sunscreen, there is a UVA rating system, and that's a little star system. It's usually out of 5. So the UVA rays tend to be more associated with skin aging, but also really important to protect the skin in TSC from those. So a factor 30 or above from the UVB protection, 4 out of 5 stars from UVA would be good. The other reason why sunscreen can be helpful is that it will prevent the surrounding skin, the normal skin, from tanning more. If you imagine tanning more around your hypomelanotic macules, the contrast between the white area and the tan skin becomes more marked and they can become more obvious. So sometimes using SPF on all the areas will just mean it reduces that contrast and makes them less noticeable. For the cephalic fibrous plaques, there are a variety of different treatments that can be done. So dermabrasion is just a mechanical way of stripping off the top layers of the skin to flatten it and allowing it to heal up. That can sometimes cause some pigmentation change in the skin. It can sometimes cause a little bit of superficial scarring. Laser can also be used. There are different types of laser depending on the main issue. If the main issue is one of redness, a vascular laser where the wavelength of light specifically gets taken up by red blood cells in tiny vessels in the skin, can heat seal down those blood vessels and make the area appear less red. If it's quite raised and bumpy, and that's the main thing that you want to do, then you can use what are called ablative lasers. And basically what they do is they just sap the top layer of the skin, just basically burning it off at a controlled thickness to flatten the skin, which leaves a wound that then can heal up. Again, there may be a little bit of pigmentary change after that kind of procedure, and there may be a little bit of scarring there as well. So what about those angiofibromas? Well, in terms of laser, you can use the same things. So if the predominant problem is one of the lumpy bumpiness, an ablative laser, something like a carbon dioxide laser, will flatten the areas. If the main problem is of redness, then using the vascular laser just to heat shrink those little blood vessels and improve the appearance. It may take a course of vascular laser treatments to really reduce that redness significantly. The other thing just to say about lasers, and this applies for the laser I've just mentioned for cephalic fibrous plaques as well as the angiofibromas, is that laser treatment is painful depending on the type of laser that you're using. And dermabrasion is painful, and some of these other techniques are painful. So they're the kind of thing that if you were doing them in a small child, or if somebody had some learning difficulties and it was difficult to do stuff with a local anesthetic, then you're looking at general anesthetic. And that's not without risk. Generally, anesthetics are very safe, but it's quite a big thing to go through. You can use topical local anesthetic cream in older people, in adults or older children who would be able to tolerate vascular laser, but you do have to consider the person as a whole and how well you think they would tolerate these procedures, because they're not inconsequential things for somebody to go through. Cryotherapy is something that can be done for angiofibromas. So that's using liquid nitrogen just to freeze the top layer of the skin. If you've ever had warts or verrucas treated with cryotherapy, you will know that this is also not a walk in the park, and it can be quite painful. And the spray devices that we use to come out can be quite frightening. So for children, particularly if young people have learning difficulties, it can be quite a traumatic thing. So again, you have to be happy that the treatment you're choosing is appropriate for that person. Shave excision is something that would be done with a little local anesthetic injection. So if you had a particularly lumpy, bumpy angiofibroma, you could just inject a local anesthetic to numb the underneath. Again, that's a painful injection, so you have to factor that in, and then just sort of slice it flush with the skin to get rid of it. And electrodesiccation is just a little heated wire, again, usually with local anesthetic, just to burn any bumps away and improve the appearance. So those are sort of quite surgical, laser, quite big things to go through to treat some of these problems. But there are some other answers which can be perhaps less traumatic and better tolerated. So here specifically thinking about angiofibromas, the ungual fibromas and hypomelanotic macules, and actually cephalic fibrous plaques as well. This drug called rapamycin or sirolimus can be very helpful. And because these are skin things on the outside of our body, this is where we would tend to use topical rapamycin. So just briefly to talk about the mechanism of why that helps. In all of us, in all our bodies, we have a signaling pathway called the mTOR signaling pathway. And this works in all of our cells. And it's a pathway which is a bit like putting your foot on an accelerator for your cells in whatever tissue that is to proliferate and to make new blood vessels to help support those proliferating cells. So this is the normal situation in all of us. However, we have breaks on that mTOR signaling. So we've got our TSC1 gene product called hamartin, and we've got our TS2 gene product, tuberin, and together they act like a brake which limits the mTOR activation. So you get signaling, sorry if I can get this to work, switches off some of that mTOR signaling to limit the amount of cell proliferation and angiogenesis you get. However, if you think about the situation with TSC, what you've got is you're missing your hamartin or your tuberin, and so you're removing the brakes off that signaling pathway. So you've got unchecked mTOR signaling leading to all this cell proliferation, and that's what gives rise to all the hamartomas in the different sites. But is there any way that we could switch off that mTOR signaling? Well, this is where rapamycin comes in. This is a naturally occurring compound found in nature, which is an inhibitor of mTOR signaling. So if you have rapamycin either topically or systemically, it switches off, it provides a sort of alternative brake in the context of TSC to limit your mTOR signaling and limit the overgrowth and the angiogenesis that you're getting. So does it work? Well, yes, it does work. So here I'm just going to show you a few examples of some published cases where rapamycin has been used. So this was a case study from 2012 of this young chap with angiofibromas on the face. You see they're quite lumpy bumpy and they're quite red, so quite a cosmetic concern. Before treatment at the top, and then after 1% rapamycin applied daily, after 6 weeks, we can see a really super improvement in terms of how things are going. Sometimes if people have very prominent angiofibromas, they can be treated with some of the things I mentioned before, like laser treatment, and then have the rapamycin afterwards to keep them at bay. This is another published case report to show you this 0.1% rapamycin, so less concentrated, ointment applied before and after once a day. You can see a really nice cosmetic result there. This guy's also got a fibrous plaque on the forehead, on the left side of his forehead, and you can see that that has also improved in appearance during rapamycin treatment. Here's another example, very, very florid angiofibromas with a 0.2% rapamycin gel. And you can see after 6 months and then after 1 year, there's been very significant improvement in the appearance of the facial angiofibromas. There's a forehead cephalic plaque, fibrous plaque, which has improved significantly as well. And down at the bottom, an amelanotic macule, and that too has repigmented really well with the topical rapamycin. So very, very encouraging results. And sort of until very recently, rapamycin was something that needed to be made up specially because there hadn't been a topical formulation available. So this is what we'd call in our pharmacies a special, where the tablets for people receiving rapamycin for various different uses would be ground up and put into an ointment or a cream to be used. Now, recently that has changed with this product, Hyftor, which is rapamycin, a 2.2% gel to be used topically. And this is the first licensed treatment for facial angiofibromas in tuberous sclerosis. So previously it was only an off-license, specially made up thing, but here we have a product that has been approved by the MHRA, who are in charge of how we can license and prescribe medicines in the UK. Now, the latest news is that this hasn't gone through the NICE process. So what happens to get a new medicine approved? You have to get it approved by the MHRA so that it's available to market. But usually then NICE, National Institute for Clinical Excellence, will assess it. Is it safe? Is it effective? And is it cost effective? And you really need that NICE stamp of approval to be able to get products funded through the NHS. So Hyftor, as it is currently, is not fundable by the NHS, although it is licensed and therefore would be available. But you either need somebody who will prescribe it for you on the NHS, but no, they won't be reimbursed for you, or privately at the moment. So hopefully things will come a bit clearer as to our pathway to be able to get this product to people who have angiofibromas and tuberous sclerosis. Is there anything else? Well, there is just something I'm going to mention for which there isn't a lot of evidence. We've talked about topical rapamycin. What about systemic mTOR inhibitors? These are drugs which have quite a lot of side effects, but they might be given in TSC, for example, for internal problems with overgrowth of tissues. So drugs like rapamycin itself or everolimus, which is a similar kind of drug, can be given orally. And those will often, as a sort of happy coincidence, also improve the skin features of TSC. But on their own, they wouldn't want you, just for skin manifestations, you wouldn't want to go through the potential for side effects just for skin problems usually. Now, beta blockers are drugs that are often given for heart problems and high blood pressure. And one of the most exciting things that has happened in pediatric dermatology in the last 15 years or so is using beta blockers to treat these things, Strawberry marks or infantile hemangiomas. So these are birthmarks that can affect children, not necessarily there at birth, but in the first few months of life can grow and get really big and lumpy and cause problems. And then they gradually involute over the first year to 5 years of life. And sometimes they can give really big problems, for example, if they're on an eyelid where they can occlude vision, and it's important that babies can see and need both eyes for proper development of vision. And it was found serendipitously in some babies that were given propranolol, which is a beta blocker by mouth, for other indications that their hemangiomas shrunk down. So on the basis of that, lots and lots of work has been done, and we know that oral beta blockers are a fantastic treatment for problematic infantile hemangiomas. Now, sometimes you get very superficial infantile hemangiomas, like these we can see here's one on an ankle and one on the side of the face. And for those ones, using a beta blocker called timolol onto the skin can be very effective at making them shrink away. Now, timolol isn't a licensed treatment for infantile hemangiomas. We go off license with this in pediatric dermatology, and we use it in a preparation of eye drops where it's used for glaucoma, where there's excessive pressure buildup in the eyes. So we use the eye drop preparation and pop it onto the skin 2 or 3 times a day and rub it in. And it's really super for superficial infantile hemangiomas. Now, I'm just going to present a couple of papers that are in the literature. This isn't a widely acknowledged treatment for facial angiofibromas, but I just thought I'd share these 2 papers with you. So this is a young man with facial angiofibromas with his TSC, and he had fractional laser, so to try and sort of burn off and remove the bulk of the lesions. But then as he recovered, he used topical timolol, the beta blocker, on the right side of his face, and no treatment on the left side. And as you can see, he had some recurrence of his facial angiofibromas, but less marked on the side where he'd used the timolol. So just one single case report. It's not strong evidence, but it's quite a nice example I came across in the literature. And then this paper that was published last year, this is a case series of 15 children with TSC and facial angiofibromas, and they used this 0.5% timolol preparation, the same as in the eye drops, applied to facial angiofibromas. There were no clinical photos in the paper, which was a bit of a shame, but we do have these graphs, and each of those shows something different. So top left, we've got a severity score, and this was really a culmination of the other 3 things they looked at. So they looked at the redness. They assessed the redness of the angiofibromas, they looked at the size of the individual angiofibromas, and they looked at how extensive they were over the face. And you can see 4 different time points reading across those graphs. So the first time point, where they're all very high ranking, was at baseline before they started using it. The next one at 1 month of using it, the next one at 3 months of using the timolol, and then they stopped at 3 months and then followed up 1 month later to see what was happening. And you can see there was very dramatic reduction in all of those parameters. And all at each time point, the statistical significance was there. So these were statistically significant differences in all of these parameters compared to baseline. So something very encouraging that perhaps would warrant further study down the line, because timolol is sort of available and there. So I think it's something that would be very interesting to look at some point. Whoops, I was going to finish there. So I don't know if anyone has any questions. If I'm able to answer your questions, I'd be very happy to do so.